Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration.
Hi, I'm Scott MacLean and I'm a director at the Seattle Study Club, and this is my practice inspiration of the day. And I'm going to share with you one of those days that you wish you never had. And this day goes back, I call it dental quicksand, because you kind of go in and you go sinking deeper and deeper and deeper. And I also want to say it's something, wish I knew then what I knew now. So if we look at this case, it's a case where we're going to squeeze in an emergency procedure. We have a patient waiting in the waiting room, and the patient's one of those type D patients who does not want to wait. So I think this is going to take me a couple minutes, so let's start the case. We look at the case, it starts actually about 7 years ago or 8 years ago when the patient came in for an implant, and I didn't really place the implant deep enough. This was one of the first implants of this type. And anyway, I got to the case, someone told me at the front desk that there's a little chip in the crown. So I said, oh, I maybe be able to bond that or fix that. So I looked at the case and said, well, bring the case in, let's have a look. And looking at the case, I said, oh my goodness, I'm gonna have to deal with this now, because this patient was about to leave and go on a vacation, which was how this all started. And I'll get back to that in a second. So we should be able to smooth this off. It's too large to smooth it off. I decided I'm gonna try to fix it. Like a dummy that would normally say, okay, let's do this at another point. I couldn't do it. So it's 8 years after implantation, and you can notice that the fractured porcelain is in a very bad spot. It happens here because we have a cement retained option, and the cement retained option uses up prosthetic space buccolingually because we only have so much space. So this getting fractured, I had a few different strategies. I could remove the crown and salvage the abutment, or I could salvage the crown for a temporary. So I chose to go through this process, and looking back at the case, maybe I should have chose a different way. So when we take this case, I'm looking at the incisal edge here. The incisal edge is going to tell me that this screw channel is probably ahead of this. This is why I had to go with a cement retained option. So the cement retained option meant that if I could stay behind there, behind the incisal edge, I could actually keep this crown and then salvage it for a temp. And so I start that process. So what are the risks when we do this? Of course, we could have incisal chipping during access, and this could happen, and it did happen. So we also could strip the screw. Because I'm trying to stay behind the incisal edge. Could this happen? Yes, it could happen, and it did happen. So I'm starting to get behind for Mr. Smith, who's out in the waiting room, and everyone's getting, Scott, get back on time. So what next? I had to start to decide what to do. So I had to cut the head of the screw off, which is never a fun thing to do. You're down inside of the crown, its sparks are flying, it feels like you're sharpening skates. So we can see here that we started to cut this off, and the crown was getting even further destroyed, meaning that I'm going to have to make a temporary crown at the end of the process. So I get to the process of the tension that's going to come off the screw, then I'm going to be able to take that crown off. That's my plan of action. So we'll see what happens. I went to take it off, the whole top part fractures off. Then I'm into a further dilemma. So in fact, this is becoming more of a problem. Mr. Smith is asking when I'm going to be ready on time, and now I have to deal with this. It's just one of those crazy days. So I look down inside, you can see that now we have a fractured piece of zirconia left inside of the implant with part of a screw. I still have a lot of work to do. So I asked, when's the next patient going to be there? They're saying, how long are you going to be? I start to get panicked because this is my worst fear in dentistry, is not being on time. So I said, I want my mama. So we always want to go back to our mama because she's going to make everything better. But this is growing from a salamander into a crocodile. How could we have this happen? This is happening because of just one of those things, one of those days. So I try to fix it, try to get out of this problem. I know that the screw is a conical type of implant system, and the abutment is sitting in, so we're going to have to make a temporary at some point on this crown. So let's decide what we're going to do. We want to get that screw out. So one of the ways we can get the screw out is by cutting the head off. You can see the complete head is cut off. So by going down inside, we want to get below the area where the top of the screw is. This is the fracture point on this screw system. So by doing so, we can also use this abutment screw removal kit, which has been designed to kind of help you to get that off. So we opened up this kit and I started to say, okay, this would be a great thing to do a presentation on because it doesn't normally happen in the middle of my day. So I started to get into some video as well. So Mr. Smith was getting irritated, but we're now starting to do our video production at the same time. So you can see here, when I take the abutment screw removal tool, we're able to get to the point where we're going to take that screw out by reversing it. So we just put it in our OsseoCare Pro, which is my implant drill, and try to back this out. You see that the head of this screw removal tool is actually designed to grab a little kind of rough area on the screw. And so we're drilling in reverse at 45 newtons, trying to get this to back out. It's just not working. So what are we going to do next? That's the question. I'm getting kind of like sweaty on the brow. I don't know what I'm going to do. So it's just not working. So we keep going at this for a little bit, and we can see that it's just going to have to be some other effort that we do. So once we get that screw out, we can go back in. We actually used a high speed with a 557, put it in high speed, reversed it, and took that screw out. But now we have a zirconia hex locked down inside of the implant. And this is going to be another problem for me because I fractured off the top. So looking at this, it becomes an issue with the conical connection is stuck down inside. If I flash back 9 years ago, this patient fell by the pool in Mexico, and of course, they're going to Mexico again in the next little bit. So we go and we place the implant, immediate placed. This was one of the first 10 that I placed with this system. I was asked to be kind of a person to try and test this system out. And you can see as we put this in, the abutment was just not very big. The space, the depth of the bite, everything was not designed to be really effective for long term. So the custom cement retained crown became a bit of a problem because of the layering effect. And this layering effect eats up space. So we really had a short wall type of abutment with rabbit ears, with retention that was poor, and this zenith that was low because the implant was not placed deep enough. So trying to get back, if the implant's not deep enough, we either take the implant out or we deal with it. We try to push the tissue as much as we can. We put the abutment on, this is 9 years ago or 8 years ago. We can see a little bit of the bone graft was kind of expelling up, but the implant is just not deep enough. We want to be 3 millimeters from the free gingival margin of the adjacent tooth. So then this is just difficult to fix at this point. So we look here, it's just not deep enough. So why was this a screw retained over cement retained type of option? It's because of that depth and also the angulation of the implant. So depth and angulation are the two key concepts for implants. So we need to have that 3 millimeters of depth over the implant. We didn't have that, and we didn't have the 4 millimeters, so therefore the problems start to happen. So by looking at this diagram, we want to make sure that the implant is deep enough. So the depth comes at the point where we're going to be 3 millimeters from the height of the free gingival margin. So not measuring from the position of the free gingival margin itself, but 90 degrees to that. So once we do this, then we end up getting a position of the implant in a poor position. And this is why the problems start to happen. So this problem started 7, 8 years ago. So looking at this new technology that I was using at the time, we used ASC technology. We wanted to use this to correct the problem by putting the implant in a position that it didn't matter. We need better depth, but we can now take the channel and get into a screw retained position. So I could have this off very quickly. So then we could also use the OmniGrip screw, which was going to design this so that we could get this into a position that was going to correct the problem. So we didn't have this technology at the time that I first started. And of course, now we're going to have a titanium interface with this tie base abutment on the bottom. So what do you need to do an ASC on Jody? We have to do a number of different things, but these are not difficult. It's more of a lab process. We need to have an OmniGrip screwdriver, but that's basically all I needed with this system. So looking at it, this lady decides to go on a Mexican trip. She had got drunk and tripped in Mexico, fallen off a raft, or she was trying to blow up a raft, and she sent me off a picture. So she said, I look like a crackhead. This is my temporary that she had on her trip. And of course, my heart was bleeding for this patient because she has this broken temporary, and the temporary now is in hands where I can't fix it. She's away. She's got 2 weeks a year for her vacation, and now her vacation is being ruined. So the crown insert itself happened when she got back. We could see that when she was coming back, we had to take the temporary that she had fixed in Mexico. So I took it off. It seemed like an easy problem, and you would never believe this. Of course, Mr. Smith, who was booked the last time she was here, was also in the waiting room, and the dentist in Mexico had decided to cement down the post. So to keep it in there nice and tight, they cemented it into the channel of the temporary. So I had more problems, and this was going to be kind of creating some problems for me because I'm falling behind in time again. So here we can't get this out, so we decided to go in and drill it out again, and of course the problem never go away. So these type of cases, we go back in, start to section it, and cut this out. I couldn't believe that someone would cement this down on a temporary, but that's what occurred. So looking at the case, one problem can lead to another. What we want to do is try to get to the problem first at hand by having things, in my mind, I want to have screw retained. So having a screw retained type of option allows me to not deal with this type of issue. If the patient had come in with a screw retained option, it would be off and then fix the porcelain and put it back on very quickly. But you can see what we're dealing with here is a lot of nuisance factors. So once the patient had this done, we could see that we could clean out the temporary, and we start to put the crown in, and the patient was going to have a little bit of chlorhexidine to clean the area out. We're going to place a screw retained crown at this point. So the implant insert becomes very simple because now we have a depth issue, but we can still push the tissue a little bit. We'll take this ASC crown and use the OmniGrip driver to position this and carry it to the mouth. So I like this, and this is kind of a key way for me to fix the case. So didn't have this option before. Now we can have the soft tissues being supported by emergence profile, lift the soft tissues up a little bit, but it's one of those cases that new options make it easier. So here you can see as the patient comes back, we have the floss threaded through so that the patient doesn't swallow it, which would make a real bad day, and in fact those are also very expensive, just joking. But what we can see is that this screwdriver fits into your old driver head, so the latch fits into your standard latch type of torque wrench, and we can take this ASC crown. Now the screw is actually not going to fall on the floor because it's snapped onto the OmniGrip driver. So the OmniGrip screw goes sliding in. We can take this to the mouth, position this into a great position, and then have this so that the patient is going to have a simple procedure. So you can see that this appointment is actually going a lot better than the last one. So Mr. Smith's not going to be as mad at me when he gets in, but make sure when you're doing these cases that you don't book the same patient after these cases. We're squeezing people in, and this becomes an issue. So as we put this crown, I'm playing with it a little bit, but as we put this in, it's a matter of screwing it down, getting the restoration to be in an ideal position, taking an x-ray, and then you can see I'm pushing the tissue a little bit, so you can't push it too much, but we can make it look better than a cement retained option, because the cement retained option does not push tissues as well, in my opinion, but some people can do that, but I can't really do that. So as we look at this case now, the patient has a nice aesthetic crown. It's going to be screw retained. If it broke again, I don't have to deal with this issue of trying to get it off quickly. I can take it off and fix it very, very easily. So the OmniGrip driver goes into your wrench. We'll tighten this down to 35 newtons, and then the problem's gone away. So we've gone through, broken crown. We've gone through strip screw. We went through zirconia abutment removal tools, so how we get the abutment out. And now we're going to tighten this down. So you can see that getting this into position now is going to make it so that the crown's going to be tightened down to 35 newtons, and then we put a little bit of Teflon in and some resin, and then the case is finished. So the way that we try to do these type of cases is we're trying to sometimes do them in too little time and not have the right type of procedure. This procedure became something very simple and very predictable once we had the ideal position and materials to use. So this is Dr. Scott MacLean, and this has been an inspirational video for you. Hopefully you'll find some of these tips helpful for you, because these type of days, we can never get back. They give us a lot of stress, and the only thing you can do is go and relax at the end of the day. So thank you.